I'm Dr. Alan Altman. I'm past president of ISWISH, the International Society for the Study of Women's Sexual Health, and presently a consultative gynecologist for menopause and female sexual dysfunction in Aspen, Colorado. What I'm going to talk to you about today is Hypoactive Sexual Desire Disorder, HSDD, and the multidisciplinary approach to both diagnosis and therapy. These are my disclosures, and you see the objectives for my talk. I've lost my sex drive is becoming a very common complaint in the office setting. Of course, we all deal with time and knowledge issues. Do we have time to spend, like I do, with a patient 60 to 90 minutes? Of course, that's unrealistic in the general office setting. But there are also knowledge issues that are a problem. That's why I always suggest that clinicians go to iswish.org and see the instructional courses that ISWISH runs at least twice a year, as well as the annual meetings, so that you become more familiar with the knowledge of female sexual function and dysfunction. That will help us in dealing with these patients and knowing what we can do ourselves as clinicians, as opposed to when we need to refer, which will frequently happen. What's our thought process going to be when this patient comes to see us with this kind of chief complaint? What do we think about? What kind of questions do we ask? What are the multidisciplinary areas that we need to be aware of? Well, to start this discussion, let me remind you that in order for there to be a sexual dysfunction, there needs to be distress. If she has no sex drive, but her partner has no sex drive either because of a medical or surgical situation, there is no dysfunction. There is no distress because she has or her partner do not have distress about the situation. Let's start by looking at the phases of human sexual response and how they have changed over the last 3 decades. We first start with the linear progression proposed by Masters and Johnson, where you started with the phase of excitement, it then moved to plateau, finally orgasm, and ultimately resolution. Again, a linear progression, important to understand that. Helen Singer Kaplan then took this first phase of excitement and properly divided it into desire followed by arousal. Desire happens in the brain. Arousal is more peripheral and associated with vasocongestion and increased blood flow. So you went from desire to arousal. She eliminated the plateau phase because it was really part of orgasm. So it's desire, arousal, orgasm, resolution. And this held for many years. And now we are looking at the biopsychosocial model of female sexual response, where we have 4 intertwining circles. Of course, biology is an extremely important part of this, having to do with physical health, endocrine function, neurobiology. And of course, we add the interpersonal area, which has to do with the current or past relationships and what is going on in one's life impacting these relationships. Most importantly as well, we have the psychology area where we can deal with performance anxiety, impaired self-image or depression, and overall within this whole area is the sociocultural. What's the environment that this couple is dealing with or this patient is dealing with? What's her upbringing, the cultural norms, religious norms, expectations, all of that. So this was the biopsychosocial model of female sexual response. Rosemary Besson brought us the more recent model. This is the intimacy-based model of female sexual response, and it is a cycle. It is not a linear progression. And what's interesting about this response cycle is that it posits that women begin in a position of neutrality with respect to sex drive. A woman will seek out emotional intimacy. She may not have a spontaneous desire for sex, but she is seeking out emotional intimacy, and by doing so, she becomes receptive to sexual stimuli from her partner. These sexual stimuli can cause her to become sexually aroused. And then once she is aroused, then she accesses her desire. So the arousal happens before the desire. And we tend to call this responsive desire because it happens after arousal as opposed to spontaneous desire, which would happen before arousal. And then ultimately she would achieve emotional and physical satisfaction. So the key here is that she starts in a position of neutrality. There is no spontaneous desire. And the desire can enter all along this cycle, this circle, at different portals, depending on how she is responding. Ken Pollack, a psychiatrist who does an awful lot of sexual and partner counseling, wrote in a textbook that Besson submits that a woman will frequently, but not always, start sexual activity from a position of neutrality without any sexual hunger. But once stimulated, either subjectively or physically, her desire will subsequently be triggered by the arousal she experiences. In essence, women's desire is often responsive to stimulation and does not precede it. This concept of responsive desire is extremely important in dealing with a patient who comes in and says, my sex drive is gone. Yes, this is somewhat complicated. And I always show a slide in my lectures comparing the complexity of this female sexual response to that of the male, and a picture is worth 1,000 words, as you can see here. So the true complexity of desire in women, it can be spontaneous or responsive. It often correlates with the length of the relationship. In general, the longer the relationship, the more apt she is to have responsive instead of spontaneous desire. Because you become used to being with your partner, and that grudgy inside your abdomen where you've got to have sex, you want to have sex, the hunger is there, is often put aside with time. Now, spontaneous desire may have the potential to return, especially if it's with a different partner. Now, an important statement here at the bottom of the slide. In my experience, approximately 60% of hypoactive sexual desire disorder is not HSDD, but is in fact responsive desire. And when you point this out to a patient, if in your questioning you realize that her desire is responsive, because she says to you when you ask, do you have sex? Yes, I do. Well, if you have no spontaneous desire, why do you have sex? Well, I want to please my partner, or I know it's going to feel good later on. Well, at some point while you're having sex, do you feel like you're turned on and you do have desire? Oh, yeah. After my partner stimulates me, then I get turned on. This is normal for you, and you'd be amazed at the response from patients and the gratitude for pointing this out. And when you point it out, you can say to the patient, since you know that there's an endpoint that's going to be satisfactory and good for you, that you like that feeling, you can then initiate sexual activity, knowing that even though you don't have the sexual hunger at the time, you will get it later during the actual activity yourself. And this is extremely important and helpful for our patients. Now, the primary sex organ in women is the brain. And in the brain, there are excitatory versus inhibitory neurochemicals. And I want to point out something that's extremely important as well. All successful therapies, whether they're placebo, sex therapy, non-hormonal or hormonal therapies, improve desire and lower distress by changing the balance between excitatory and inhibitory neurochemicals in key regions of the brain. Here's a diagram of that. In the woman with HSDD, the inhibition neurochemicals are heavier and they bring down this scale. Those neurochemicals involved with inhibition include serotonin, prolactin. The ones involved with excitation include estrogen, oxytocin, dopamine, norepinephrine. You see them listed here. And it is this balance which will help determine which way the patient will respond. Now, Flibanserin was approved by the FDA 2 summers ago, and it was the first, quote, sex drug, unquote, approved for women. Flibanserin is intended for the treatment of HSDD in premenopausal women not caused by another factor. If her partner is abusive to her, this is another factor, and it's inappropriate to use Flibanserin in that situation. It's better to get counseling or call the police, either way. But my point is, Flibanserin is intended for the treatment when this is not caused by another factor. The oral dosing is 100 milligrams every night at bedtime. Now, it's not really a sex drug because one does not take Flibanserin episodically when one wants to have sex. It is a nightly use drug, so it can't be called a female Viagra. You have to load the drug by taking it nightly. And if it's taken nightly, because it can make you sleepy, so it's taken at bedtime. If the patient does not respond at 8 weeks, 2 months, she is generally going to be a non-responder. And that's very helpful because you don't have to be hesitant to try this for a long period of time on your patients, because if they don't respond by 8 weeks, you can call them non-responders. Now, just to summarize the efficacy of Flibanserin, it is a novel, non-hormonal agent that's the only FDA-approved medication to treat premenopausal women with generalized acquired HSDD. It is a restorer of sexual drive. If someone never had a sexual drive, Flibanserin is not going to give it to them. It's going to restore the sex drive that has been lost. And it modulates excitatory inhibitory neurotransmitters and has shown efficacy in improving sexual desire and the number of satisfying sexual events. Flibanserin has demonstrated efficacy, and the safety profile of Flibanserin is acceptable. And it increases dopamine and norepinephrine. Both are responsible for sexual excitement, while transiently decreasing serotonin, responsible for sexual satiety or inhibition. Very important slide. Proper diagnosis leads to optimal therapies. ISWISH will teach you, and as a sexual medicine specialist or as a general clinician, this is a multidisciplinary area, and both diagnosis may be multidisciplinary as well as therapy. Now, Ken Pollack and I just wrote a chapter in a textbook called Integrating Behavioral Health and Primary Care, and the chapter was assessing and treating sexual problems in an integrated care environment. This is for primary care clinicians. You don't have to be a sexual medicine expert to gain knowledge from this chapter. And what we teach in the chapter is that you must always think that there's more than what is obvious. You've got to Sherlock Holmes this process. It happens in the way and what questions you ask, what the patient answers, and where your thought process goes to what else can be involved here. Be discerning. Think like the other specialties. If she says, my sex drive is gone, it was always fine, I'm on estrogen, perimenopausally, and you think that you've whittled down already what the real problem is, forget that. Look to the relationship, look to the upbringing, look to the other disciplines to be sure of both diagnosis and therapies. Abe Morgenthaler, one of the well-known urologists at Harvard Medical School and a very well-known sexual medicine urologist, wrote the Viagra myth discussing this same thing, the same viewpoint, that yes, the Viagra might help you get your erection back, but that doesn't mean sex is fine. What are the other areas involved? The relationship, your feeling about yourself, performance anxiety, all of that needs to be looked at. It's not just the medication that works. So think out of your box here. Think of the other specialties. Make this multidisciplinary, and it will help your diagnosis as well as therapies. In order to prescribe or dispense Flibanserin, you must be certified. So both clinicians and pharmacists need to be certified. And this is due to the concerns about the alcohol challenge study. In fact, absolutely no appropriate use data is out there to support this. So let me explain that. Looking at 11,000 women studied over the years using Flibanserin, there was never a signal of any problem in 60% of the patients who were moderate social drinkers before they came into the study. The other participants were not. So 11,000 women, approximately 60% of them, moderate social drinkers, never a signal in any of the studies we did that there was a problem with concomitant use of appropriate alcohol intake. The FDA decided that there needed to be a study called an alcohol challenge study. I suspect the reason they did was because you take the drug at bedtime because it can make you sleepy, and they were afraid that if you were sleepy and you had alcohol at the same time, there could be problems. So instead of patients taking the drug at bedtime, which when they're supposed to, they took it at 9 o'clock in the morning after taking in by mouth between a half to a full bottle of wine. And without anyone's surprise, there were people who were getting dizzy or passing out. Most of these study subjects were men, a few were women. Well, if you take the drug improperly, and you take it during the day and you drink a half to a full bottle of wine after taking the drug, certainly there can be problems. But that's not the appropriate use of this medication. And I will touch on this a little further in our discussion. So let's get to a case study. And this is especially important for not only a multidisciplinary concept, but important for psychologists who do sexual and relationship counseling. This was a patient referred, a heterosexual couple, he 52, she 48, married 18 years, and in couples sex therapy for 4 months, with a leading relationship psychologist, Dr. Marian Brandon in Boston. There were multiple issues involving HSDD with this couple, but Dr. Brandon saw fit to refer the patient for a physiological workup, even though it was obvious to her there were many issues, psychosocial, culturally. When I saw her, I noted that she was early perimenopausal, with occasional irregular menses. She didn't have any vasomotor symptomatology, hot flashes or night sweats, did not have vaginal dryness or pain with intercourse, dyspareunia. That's extremely important because a large portion of perimenopausal women, they're not postmenopausal, they're peri, will not have their sex drive because of vaginal atrophy and pain with intercourse. After all, who wants to have sex if it hurts? So it's very important to look at those questions. And after her workup and finding that there was no obvious physiologic reason other than the fact that she was perimenopausal, I suggested a trial of Flibanserin therapy. Now, why would I do that? First of all, I had a discussion with the patient and her husband explaining what Flibanserin was and how it worked, and answered their questions. I reviewed the potential side effects, which could be fatigue or dizziness or potential hypertension, especially if you took it in the morning and went about your business not being asleep during the day where you could have problems with fatigue. I reviewed the alcohol situation, as I reviewed with you just now, and said that there was a boxed warning about using alcohol with taking Flibanserin. I explained to them, and this is what I do in my own personal practice, and this is anecdotal, I explained to them that the best way to do this would be the first 2 weeks on Flibanserin to avoid any alcohol intake. Then in the second 2 weeks to add on a glass or so of wine, if that's what your normal intake is. And if you found a problem, go back to no intake. And for the vast majority of patients on this drug, they will find no problem, and you can get back to social moderate alcohol intake after that month is up. What was interesting, I also described the driving study that the FDA had requested before the drug was approved. And in the driving study, patients either took the drug or placebo at bedtime the night before, which is the appropriate use of the drug, and then were put in driving booths for these kinds of studies the following morning. And in fact, what the study demonstrated was that the patients who were on drug showed a statistically significant better function in driving than the patients on placebo. Interesting results. I also go over with the patient and her partner the expectations on Flibanserin. Don't look for a change day to day. That was one of the problems with the initial studies. The FDA said, we want a daily diary. Well, that doesn't make any sense to ask a woman every day, how's your sex drive? Is it better than yesterday? You do it monthly. Don't look day to day. Sit back, just see how the long-term impact is, and most important, to continue their counseling, the relationship and sexual counseling with Dr. Brandon back in Boston. Okay, to sum it up, 3 months later, they're still in therapy with Dr. Brandon. But their sex is back in their lives due to her increased desire from the Flibanserin therapy. And the therapist clearly notices less frustration and more optimism to move forward by both patients. Before adding the Flibanserin, there was anger, there was frustration. You could palpate it during the session. And so the upshot of adding the Flibanserin is that it will likely shorten their therapy and help achieve successful resolution more timely. Why not take a year or two of couples therapy and shorten it to 6 or 8 months if we can do that by increasing her drive and making her more receptive while these other problems are being worked out. Hence, you see the result of both modes of therapy. So, to summarize, it's dosed nightly. It's not an episodic drug. You don't take it before you want to have sex. It needs to be taken every night and taken at night because it can make you sleepy, not dissimilar to natural micronized progesterone in postmenopausal women who have to take it at bedtime because it can make them sleepy. Responders will show by 8 weeks. If they're not responding by 8 weeks, they are probably non-responders. They don't need to stay on the drug. Don't get stuck in that solitary diagnosis. Broaden out your thought process. Think out of the box. Think like other clinicians in other disciplines, and be open to the fact that it may not be just what's obvious to you. Get certified. That's important. Discuss alcohol appropriately, as I suggested to you. There has been off-label use in postmenopausal patients on hormonal therapy, on appropriate hormonal therapy, which to me is transdermal estrogen and oral natural progesterone. The studies demonstrated success, much like we saw the success in the perimenopausal patients. And one other anecdotal piece to add, in my personal experience in my office with my patients, they have frequently mentioned to me that there's been weight loss involved while they were on this drug. This is purely anecdotal. It is not closely studied, but I mention that to you in passing. Well, I hope that this has been useful to you and helped give you the concept of broadening both diagnosis and therapy, and also helping the psychosocial cultural therapists who are listening in that for you as well, this can work to help shorten the important and necessary therapy that you are giving to this couple. Please go to email at info@herdesire.net, as you see listed here on this slide, and continue the dialogue with your peers and your colleagues. Again, I thank you for your attention. I am Dr. Alan Altman, and hope this has been helpful to you.